Thanks a lot. It's the time for discussion. We had 3 excellent talks on 3 key questions. So maybe the orators, if they could come back here, and so it will be maybe more. I'm sure that we will have questions. Otherwise, we could. You have many, and we have also one from the. Maybe we can start with the question of Professor Elie Kogan. He's asking about the evaluation of NT-proBNP. There is subtle changes in renal function influencing NT and proBNP levels. How to correctly assess the evolution of NT-proBNP, taking renal function into account?
Yes, so we already know that NT-proBNP is influenced by the renal function. So we published several years ago that we probably need to use a BNP, or it can be easier to use a BNP that is less influenced compared to NT-proBNP in all patients with an estimated glomerular filtration rate less than 30. And also the German group published a few years ago the importance of looking also other factors such as the presence of atrial fibrillation that can change the value of the numbers of NT-proBNP. So again, probably forwarding what Monique said, the expertise in looking also these numbers is also a key importance, and the collaboration with cardiologists. So in the referral in the expertise centers is important, the collaboration with cardiologists. So looking the numbers, but also looking all the other cardiology issues that can explain the value of the NT-proBNP.
There is another question from Doctor, I don't know if it's a Doctor Vidali. How do you ramp up, yes, it's a doctor, venetoclax in AL amyloidosis? First question. Second question, do countries who use teclistamab use it continuously or until hematological complete remission?
Yeah, I will answer. I can't answer the venetoclax because we don't have access to that, but perhaps somebody else can. But for teclistamab, it's very interesting. So that's the bispecific drug, okay, that is being used and approved in myeloma, and that's also a continuous treatment. But I do know that also in myeloma we have this discussion: should it be a continuous treatment? And we hope actually to start a trial in the future with stopping treatment and perhaps restarting again, even in myeloma, in relapsed refractory myeloma patients. And in fact, there has been trials in which the drug has been stopped, not the teclistamab, but another type, and the remission in myeloma can be very long. So we don't have formal trials yet in AL amyloidosis, but I think very important in those trials will be that they stop treatment like we did in daratumumab, in the daratumumab trials. That will be a stopping moment and also perhaps a restarting moment. But at the moment, the drug is not approved in AL amyloidosis, so I think we can use it a bit being liberal with the inclusion criteria, and at the moment in the Netherlands we can't stop it because it's on a compassionate use-based program, but I would love to hear experience from other sites, other countries where they perhaps stopped treatment and how long that remission can be achieved in patients. And the other question was about?
There was the question, so maybe Arnaud can help for the ramp-up for venetoclax and the bispecific.
Venetoclax we use 400 milligram once a day, monotherapy, and if it doesn't work, we add bortezomib and dexamethasone, and you don't need to have a ramp-up. There's no lysis syndrome in amyloidosis, like in myeloma. And for bispecific, I think we have to do short treatments. So maybe 3 months, 6 months, I don't know. And we have to give every 15 days or every month. And I think the response will be very longer than in myeloma.
Yes, I couldn't agree more regarding the bispecifics. We should learn from experience in myeloma, and that's especially for patients with AL, where usually the clone is much smaller. We don't need to give such a dose-dense regimen, but a kind of a short induction when you have a good response, some consolidation or maintenance, and then stop the treatment. And with venetoclax, likewise, we have limited experience just because of the limited accessibility. But also here you have studies where they push venetoclax up to 600, 800 milligrams doses, but also in AL probably 400 milligram is the best fit in terms of efficacy and tolerability.
Yes, I think that there is until now few reports about bispecific. We had only 2 patients, but we did also once monthly and only for 6 months. And in fact, you have very, very rapid answer. And we know that the risk of infection is so high, but we still have, as you said, need more data.
Okay, we take a question from the room.
Hello. Just a little question regarding the statistics on relapses. Do you have any statistics on that? Do most of the people relapse, or are there many people who don't relapse? Or what is the time schedule, or what is the time frame over which relapsing occurs?
Not exactly. I think most of us believe that most patients will relapse. That's why we will never say goodbye to each other. So you will remain under the control and of supervision of a hematologist every 6 months, perhaps later on, or once a year when you're very long in remission. But I think there are not many hematologists will say you're cured, and so I think, and that means that many believe that a relapse will occur. For autologous stem cell transplantation, it can be extremely long. So people can be in remission for 15 or 20 years. People can also relapse within 6 months. But it can be extremely long. So that's the good news. For the new drugs, for the Dara-Cybo-D that has been talked about a lot, we don't know yet because the trial is not old enough to have that data. I don't know, so in the end we think like 95% of patients will relapse, but I don't have any numbers on exactly how many within a year or how many within 5 years with which treatment was given then. It would be a very interesting analysis, but I don't have those statistics, but perhaps London, Ashu has them, or perhaps you have them?
Well, the other point is what is the real definition of relapse? So if a patient moves from a complete response to a small monoclonal protein without any signs of organ damage, it's a real relapse or not? Because do you have to start a second line or a third line or whatever, or not? Because, or from an MRD negativity, the presence of MRD positivity without any signs of organ damage or organ dysfunction is a real relapse in terms of progression. This is another issue. So I also don't have numbers. I still have some really old patients that were treated with autologous stem cell transplant that are still in remission, like also more than 10 years. But obviously we don't have enough time to say how many patients after 24 months of daratumumab will be 10 years without any drug. So,
can I ask a question now? I have a question about stopping the treatment as well. Is the first condition is there should be complete response, because there are patients, hypothetically, but that have, let's say, a good partial response, and that is also stable, so it changes like that, it stays like that with at least 6 months or so. There are no signs of extra organ involvement. Is then also stopping a treatment can be considered, or
yes,
not the case?
Yeah, so I think you're talking about patients that have a very good partial response. So
not very good partial, but let's say a good partial. Let's say 80% or so.
80% reduction. Yeah. So I think that's the beauty, but also the difficulty of this disease. That for every exception you can have some clarification. But it's very important that sometimes we don't know why is it not called a complete response. Sometimes it's the complete M protein, so not the light chain, but the complete heavy and light chain M protein that's causing that you can't call it a VGPR or CR, and that M protein will not have an effect on your organ. So sometimes it's that. Sometimes your light chain is not going down because of other reasons, because of your kidney function, for example. If it's less, it won't have normal values when you use the free light chain assay or one of those assays that are involved by your kidney function. So there can be more details in that, but in general, I do believe when you are giving a treatment and the patient is in remission in the plateau for 6 months, then you should make a decision. Stop treatment and observe carefully, or change treatment to see if you can reach a deeper goal, but do not continue with this treatment because the optimal effect has been achieved.
Okay. Thank you.
Okay.
May I just, to add on Monique's comment, I mean, let me make a comparison with myeloma. You know, you have myeloma patients who, let's say, they only VGPR. But, okay, we just watch and wait because they're not considered as high risk for early relapse. Some patients go back to an MGUS state and they might never progress or progress only after many years. In contrast, we have myeloma patients, what we call high risk. And even with a small trace of disease, there is a risk for relapse, sometimes imminent relapse. And for AL amyloidosis, personally, I would call this residual disease as a high risk for further organ damage. And in that regard, I think you're fully right that if the response is suboptimal, it's better, if possible, to change the treatment to get a better level of response rather than waiting until the organ damage becomes bigger and bigger.
Okay, thank you. There's another question from the audience, I think. No?
Yeah. It's from
Yes?
the duration of response. When you have a very profound and rapid response, like CR after one cycle, the duration are, in general, long. You have long-lasting response. I have a patient who is in complete response for 21 years. Now, after MDEX, another one, 19 years after 5 cycles of bortezomib dexamethasone. A third one, it's 18 years after VCD. So you can have very, very long lasting response.
Also with non-transplant regimens.
Yeah, sure.
Yeah.
Mm-hmm. Okay, so a question from the audience.
In relation to the peripheral neuropathy caused by bortezomib, is the damage likely to be permanent? So in other words, will the pain last permanently or does it go away?
Well, that's an excellent question. So there have been many studies 10 to 15 years ago with bortezomib in myeloma. And overall, one can say that the neuropathy induced by bortezomib will be reversible in 2 out of 3 patients. What does reversible mean? Well, it means it gets better or it completely disappears. But nevertheless, 1 out of 3 patients will continue to have this sometimes very embarrassing peripheral neuropathy. And in order to try to prevent that patients are in that 35% group of long-term or even irreversible peripheral neuropathy, it's so important that during the treatment, when there is neuropathy, that it's always captured by the healthcare nurse, by the physician, and that appropriate measurements are taken. And because over the years there are, let's say, many algorithms just to score it and then to know how to act upon that.
Okay.
Yes, please.
I have a question. Is there a ruling of registering the data of AL amyloidosis treatment? And if yes, what is the duration? So to get some experience, you have to register data for treatments, or are there rules, or does every hospital do it by itself and say, okay, we hold data for 1 year, 2 years, 3 years treatment? What are there rulings?
I think perhaps what you mean are guidelines? Guidelines how to treat patients?
No, to hold data, to register data of the treatment. So you make statistics and say, okay, if there are some side effects of some medicine or drugs, and how is the development, when does a remission come or not? So you have to hold data. Is there a registering rule for all hospitals in the Netherlands who deals with AL amyloidosis, or do you do it by yourself to say, okay, I have 40 patients and I held the data for 3 years? Statistics.
May I try to answer? So for Italy, at least, every new drug, for example, Daracybordi was approved just in February 2023, just to make as an example. We have to, just few centers are the centers that can prescribe. Few doctors were identified as prescribers of this combination, because you have to fill a registry that is a registry from the Italian Society of Pharma Industry, or pharma evaluation, so it's a government authority. And so you fill the form or eligibility criteria. It's almost the same of the eligibility criteria of the Andromeda clinical trial, almost. And then every month you have to say if the patient has obtained response or not, and have side effects. So for every new drug, and this was for bortezomib 10 years ago, this was for lenalidomide, this was for lenalidomide and all the others. But this is a national authority evaluation. It can be used for statistics, but it is difficult because sometimes they just kept some regulatory issues, not all the aspects of toxicity, not all the aspects of response. For example, they are not asking, they are asking free light chain measurement at diagnosis, but not at response. They are just asking, is the patient responding, yes or no? And so you can say how many patients respond, but how many patients in complete response or not, you cannot say. So this is an Italian way that is a regulatory issue. For a scientific point of view, we have a Eureka registry now that combines data from several centers in Europe, Pavia, Utrecht, Heidelberg, and Pamplona. That is a joint effort under the patronage of the European Joint Program for Rare Disease. And so we are trying to build this kind of registry. We also applied for another registry that was not funded last year. And so we're trying to combine, because, you know, the point is that I have my own data set, Monique has her own data set, Heidelberg and Ashu has his own data set. And so all the data sets have the answers, but for these data. So probably the only way is to have a larger registry, as you mentioned, that is not does not exist yet. Okay.
Okay. So we have several questions from the chat too. To move on, so there's a question from a patient called Jumara Nascimento, who says, I have multiple myeloma and AL amyloidosis. I had a transplant, so ACT, with a maintenance treatment, lenalidomide 10 milligram. Do I need to change treatment to daratumumab, as this is the newer treatment?
Well, I think in general, it depends on the goals of treatment. So if he is in CR, perhaps also MRD negative, perhaps I don't know how long he's taking lenalidomide, but even in myeloma we have some studies that suggest that you can stop the lenalidomide maintenance. So do not just change because Dara is the new kid on the block, but do it with fundamental questions asked. Complete remission is the goal.
Of course. So I also have a personal question here. So thank you again for your brilliant presentations, and we already had so many answers. But since there are only about a bit more half of the patients in complete hematological remission who are also reported MRD negative, so what about the interest of systematic MRD assessment in patients with complete hematological response but only partial organ responses?
Well, perhaps we can all answer that, but for me, I think that would be extremely interesting method. I would also like to see such a prospective data collection on the mass spec blood-based method, because I do notice that not every patient is a fan of repeated bone marrow examinations. Because what we do know in myeloma, it's not one MRD measurement. You should have an MRD measurement on a fixed time point and also have one later on. So that's again already two bone marrow examinations. But perhaps you have other opinions about it.
If a patient is MRD negative, we repeat it with a minimum of 6 months in between and a maximum of 12 months. So 2 or 1 aspiration every year. And just indeed, because sustained MRD negativity is even better than just being once MRD negative.
Okay, because there can be organ progression if there's complete hematological response. So that's the point for some patients. That's why.
Yeah. So the diagnostic tests that we have, immune fixation in serum, in urine, FLC testing, do have their limits. And with other methods, we can measure much more sensitive, and especially for patients with organ progression. But being in a classical complete remission, you can have these methods will be very interesting to explore. Yeah.
Thank you very much. So there are other questions from the chat. Heike Wolf asks, how can you tell if continuing a treatment is too much and over-treating?
Yeah, so that's a difficult one. So that's why I advocate for expertise centers. I think complete remission and MRD testing can be very helpful in that. Also side effects, so the patient tells you what's still tolerable and what's not tolerable to this patient, and what the aims of this patient, how active he is working or traveling or things like that. But it's a difficult one, and I think shared decision making and not making this decision in once, but talk about it, think about it, repeat the discussion at the next visit at the clinic can help. And what I normally do if you make such a decision to stop treatment, sometimes you can also say, let's increase the measurements after that a bit. So not every 12 weeks, but perhaps now you should measure every 4 weeks. If it's going okay, then we made the right decision by stopping treatment, and we can prolong that again. If your involved free light chain is going up, we made the wrong decision, but we can restart the same treatment again. So nothing is lost in that sense.
We have still some other question from the chat. So from Debari Uria, if the patient is hematological and not in, it's the same, I think. Yeah, it's the same question that you just posed. So I will take the next one. What is the time limit for stopping treatment after a complete remission to resume the same treatment? And the second question is, do you use venetoclax as a second line in the absence of translocation 11-14? So the first, what's the time limit for stopping treatment after a complete response and to resume the same treatment?
Well, if I may, that's of course always something that needs to be taken into consideration if retreatment is possible. And in my own experience, I have patients who have over many years received 3 to 4 retreatments with bortezomib-based regimen, still with all the time a very good response. But if a patient relapses within, let's say, 6 months, or even within 1 year after that treatment was discontinued, maybe it's better then to look for an alternative treatment rather than restarting the same regimen. Regarding the question, venetoclax in patients without T1114, maybe Ashu or anybody else wants to advise on that? We have no experience with.
Being CD20 positive then?
If it's translocation 1114 negative but CD20 positive, you can use venetoclax. If you don't have the results, because you can have the cytogenetic, if the patients are only free light chain and not a complete immunoglobulin, you have 70% of chance to have a T1114. So it's reasonable to use venetoclax in this patient with light chain only.
And I think the response, because it's not only 1114, it's also the B-cell too high plasma cells that respond very well. So it's more than only the 1114s, but it's also not nothing in the non-1114. So there is some response. I think also in it's less, but it's not that there's nil.
Yeah, it's 30% of response, and I think it's not long-lasting response. So venetoclax is not the best choice for non-1114 patients.
Yeah, and I also would like to confirm what Professor Delforge is saying. If you're an AL amyloidosis patient, more likely behaving like a myeloma patient, so with fast relapses, then I think the right choice is to continue your effective treatment, because then you don't fall in the classical pattern of long remissions for several years, then restart again. But then you have a more active disease, your plasma cells are dividing much faster, you're more like a myeloma type disease, and sometimes when you are on the right treatment after your second or third relapse, and it's effective for you, it's tolerable for you, I think indeed it's better to continue on that treatment, because stopping will automatically cause a fast relapse again.
Okay, thank you. We have a last question from the chat. Is there any clinical trial or treatment to remove amyloid proteins from the heart? I think it's a topic from this afternoon. So perhaps we might learn more about this this afternoon. Are there any other questions from the audience? Otherwise, we are perfectly on time for lunch break. And so, there's another question. Okay, we take a last question. I was too quick, sorry.
So maybe yes. Oh, thank you very much. I'm neurologist, so I would like to thank every people who talking about polyneuropathy, because it's very important. As a neurologist consulting patient on the hematologic department, I can see that many of patients really suffer with polyneuropathy and sometimes ending up with wheelchair, especially patients with diabetes. So very important is to have any prophylactics for polyneuropathy after bortezomib, and it's completely abandoned in Europe. I know one small study from Japan with lafuditine, which have very good effects, but this drug is not registered in Europe, but is registered in Chinese, in India, in Japanese, so 2/3 of the world. And maybe we could start with this prophylaxis already in Europe, because it's very important from my point of view. So my opinion is not questioned.